Hi, so welcome to Decoding CTO case 48. So in this session, I came up with a case. It's a very rare complication which even I have seen for the first time. A post-investment coronary pseudoaneurysm, which is sealed by reintervention. This case also exemplifies how we can use CT angiography for procedural planning. This was one of the top 5 cases in case competition of CTO Club 2026. So, and this patient history is like this. Is a 60-year-old male, came with a NSTA and QMI. 2D echo was normal LV function and ECG was normal. CT angio was done, which showed 2 vessel disease and LCX OM disease as well as CTO of right coronary artery. In the index procedure, PCI to LCX was done, but CTO PCI to RCA was failed, which culminated in investment procedure. And subsequently, patient came with a pseudoaneurysm, and we handled it, and I'll show you how we handled it. This was an index coronary angiogram. You can clearly see there is a tight lesion in LCX extending into OM1 and also another lesion after OM origin. And LAD, there is an intermediate lesion, and we did an IOS for this LAD. Lumen areas were more than 4 mm square. That's why we decided not to do anything to LAD. Yes, this was LCX lesion and this was LAD lesion. This was RCA. You can see there is a total occlusion with a side branch at origin of the occlusion, so clearly showing an ambiguous proximal cap. And this was injection from left system showing right coronary artery. So this I consider as dual angiography equivalent with a single catheter coronary angiogram. So wherein you can make out CTO length as well when you take imaging in same view by injecting antegradally and retrogradally. This was a lesion which was handled in the index procedure. So we just stunted from LCX to OM. We stunted from LCX to OM, and this lesion we did a cutting balloon followed by drug-eluting balloon. We had a good result under IOS with less than 30% of area stenosis. That's why we just did DEB and left it. So now if you analyze this CTO, right coronary artery CTO, this was his CT coronary angiogram. You can clearly see the proximal cap is ambiguous. You can also notify in dual angiography here. So it's ambiguous and there is a side branch. And in fact, there is also calcium. You can see the cut sections of proximal cap here. So you can see there is a lot of calcium sitting in the proximal cap, everywhere. And coming to the distal cap, if you can see here, this is the distal cap. And again, even at the distal cap, there is a side branch. So, and the distal cap again is calcified. You can see the calcium in the cross sections of distal cap. So essentially it's a ambiguous proximal cap, ambiguous distal cap, and a lot of calcium in the CTO segment. And also there is a tortuosity within the CTO segment, which I'll explain you here. So if you see, this is a volume rendered view where you can clearly see the tortuosity within the right coronary artery, and you can see this is a MIP image which shows the angulation within the CTO segment. So this angulation usually you see in right coronary artery, either proximal or mid or distal. Always angulation will complicate your wiring strategy, whether it is antegrade or retrograde or reverse cart. So this has to be kept in mind, while devising your wiring strategy and possibilities of bailout if it fails. And this is a CTO body, which clearly shows, you can see the cross sections here. There is a lot of calcium, so within the CTO body itself. So taking all these points and putting it to your JCTO score, you will understand there is an ambiguous cap, there is calcium, and angulation is there more than 45 degrees, and length of the CTO is more than 20 millimeters, which makes you it's a most complex CTO with a JCTO of 4. And wiring strategy is the first thing is ambiguous cap. So if you can take IVUS into this branch, probably we can do an IVUS guided cap puncture, but it looks there is a lot of calcium here, which CT also showed. So we may not be able to really send IVUS into it. In that case, we can just probe and send wire into RCA, keeping the mobility of the wire as a guide to understand it is within the vessel architecture. So that's a blind probing and going further into CTO versus IVUS guided cap puncture. So that's for antegrade. So once that antegrade wire is in, since there is a loop within the CTO segment, it is imperative to come even retrograde, to have a retrograde wire, to use it as a marker wire technique, and wide subsequently either you send antegrade down or retrograde up to connect spaces. So connecting spaces, either you can use a marker wire to send your antegrade wire into retrograde lumen, or bring retrograde wire into antegrade lumen by doing a reverse card. So that should be the wiring strategy, in this case. This is dual angiography. You can see, there is a side branch at the distal cap. And you can see, we in fact wired, blindly as the IVUS catheter was not going into this branch. So we did a direct proximal cap wiring by probing. And once the wire is into the mid RCA, you can just observe the wire movement along with RCA. If it is moving along with RCA, that says you are within the vessel architecture. But the problem here is the loop within the CTO, which already I showed in CTO. So you can in CT, this wire, if you see the direction of the wire versus the distal vessel visible, it clearly makes you understand there is a loop. So in this situation, it is always better to have a retrograde wire to advance your antegrade further, or to do a reverse cart or whatever. So that's the reason we went retrograde, and we injected with microcatheter retrogradely. And you can now understand there is ambiguous distal cap, which I already showed you in CT. So there is an ambiguous distal cap. Whenever there is ambiguous distal cap, most likely it will be a hard cap. So, and also when there is a side branch just beside your distal cap, that is what makes it primarily ambiguous. Also makes cap very harder. So we have to anticipate a hard cap in such situations. So we started wire escalation from Gaia next 2, it didn't advance, so then Gaia next 3 not advanced, and further escalated to 114. This is usual escalation strategy of mine. Even 114 didn't perforate distal cap. So I don't have Sasuke then. So if Sasuke was available, you can take Sasuke retrograde on the wire in RV branch, and that gives you more support for wiring. So essentially it enhances your wide support, and so that the tip load can be delivered completely onto the distal cap. But that was not there. So we moved on to retrograde knuckle. So I just did a knuckle retrograde, you can see here, with the Gladys MG wire to go just subintimal across the distal cap. So once that is done, it disturbs basically the distal cap, And we can come back and go with wire escalation again to further traverse CTO segment. So that's what I did. Removed the knuckle and then went back to this guy next to, and advanced. Now you can see guy next to got advanced into CTO segment, and now we can see both wires are almost approximating. But the challenge here is the loop within the CTO segment. So that's when it becomes really difficult to go to further advancement in your wiring strategy. You can see in this process we noticed an aortic dissection here, so you can see contrast which is visualized in the aortic wall, and that's when I had to change my ampulature guide to JR. You can see this is the JR guide, so which came in place of ampulature to avoid further dissection, expansion, and creating problem to aorta. And we also brought guide extension. I think this is mostly trap liner, and then a microcatheter and with wire. So despite all the effort of reverse cart, we were not able to connect spaces, mainly because there is a loop in the CTO segment. I tried conventional reverse cart, tried guide extension, assisted reverse cart, tried with directable wires retrogradely like Gaia Next and Gaia Next 3, and also tried with Gladius wire, but nothing worked out in this case, and we failed in bringing retrograde wire into antegrade lumen. That's when I did an IVIS to bail out, and then I understood this is my retrograde wire, which is in a different lumen from antegrade wire. So this is the antegrade wire and antegrade IVIS catheter, which is clearly in a subintimal area. So retrograde wire is in true lumen and antegrade wire is in subintimal space. And to just achieve success, so as a retrograde wire is in true lumen, I further knuckled the retrograde wire to take wire into subintimal space, so that as antegrade is subintimal, so we can connect spaces easily. So we also did both antegrade knuckling, retrograde knuckling, and bringing wires into subintimal space, then doing externalization, but nothing worked out that day. So finally ended up in doing a plasty, that is investment procedure, whatever you call. So we did an investment procedure, and this is post-investment IVIS, which you can see. It's all subintimal antegrade, and so an entire space is opened up along the CTO segment, and you can see this is at the ostium of RCA. It is subintimal, so even wire is subintimal, even close to RCA ostium. I think mostly that is because of the guide-induced dissection. So when we removed guide and exchanged to JR, that's when the wire went through the subintimal dissection at the ostium. So, and this is a true lumen, so at the RCA ostium, and I can see it's all subintimal space, and this is where it is. I'm coming to true lumen and exactly close to the RCA ostium, and you can also see some extension into aorta here. So you can see here, and this is subintimal, this is true lumen, and IVIS is back in true lumen, and this is all IMH, which is right at the ostium of RCA, extending into aorta. So we stopped at this juncture because we don't want to do further harm to aorta, and I did a final small puff just to understand. You can see contrast is just going into aorta. So never inject into such vessels. So that's very important. Every injection will cause or expand hydrodissection further. So we brought the patient back after 8 weeks, and we did an angiogram. So you can see now, so that CTO segment is completely opened up, but to our surprise, there was an aneurysm within the coronary there. And you can see here in RAO view, so there is clearly a pseudoaneurysm which was sitting in the mid RCA. So that's when I stopped going further, because I wanted to understand the anatomy further to plan meticulously my procedure. So you can see we did a CT again, so just to understand the RCA anatomy. If you can see the CT here, so there are two lumens in the proximal RCA. So, and this is the true lumen and this is a false lumen. You can even see the break in the intima here, and this is the dissection flap. So, and this is a false lumen, and you see the continuity of the false lumen to the aortic intramural hematoma. There is no active contrast leak into aorta, but you can clearly see increased thickness of aorta here. That is basically aortic intramural hematoma. But out of the two lumens here, one lumen is ending here and the other lumen is continuing here into the mid RCA. That is exactly this place. So there is a true lumen. True lumen is ending as a blind sac, and that is continuing into this side branch, and false lumen is going and continuing as a pseudoaneurysm in the mid RCA. So understanding this anatomy is very, very important, to devise a wiring strategy in this patient. So you can see here, I'm just rotating, CT just to understand which lumen is continuing into mid RCA and which lumen is ended as a blind sac into that side branch. So for you to understand easily, I created this graphic. You can see here, this is a true lumen and false lumen. You can see this is a true lumen, and which is continuing into this branch, and this is a false lumen which is continuing into the false lumen further in the mid RCA. And this is all the true lumen which is compressed by earlier procedure, and there is a residual CTO segment here followed by all the true lumen of right coronary artery. So with this anatomy, so we started planning what we can offer to this patient. So what came up to our mind is, so first thing, I have to achieve a wire position like this. So get a wire through the true lumen and then perforate here back into false lumen here, and then across the CTO segment into distal RCA. So this is the wire position I have to achieve. How? I'll come to it in the next slide. So once I achieve that wire position, then you open up the CTO and put a drug-eluting stent here. So this CTO part is addressed. Next, so you put another drug-eluting stent here so that you can seal this flap back to the wall, and all the subintimal space here is closed, and which completely seals the danger which you can cause to aorta as well as distal vessel. Next, what is left here is just the pseudoaneurysm. So take a covered stent and put covered stent from this overlapping proximal as well as distal stent covering entire pseudoaneurysm. So this plan basically makes you gives you two leeways. One is you are closing down the proximal space, that's pseudo space which was created in the earlier procedure completely, and you are putting a covered stent overlapping to two DAS, which even minimizes the covered stent related restenosis, which is most commonly happens at the edges of the covered stent, that is chocolate wrapper stenosis of covered stent. So that's also get minimized. So this is the plan. So this is the covered stent which we planned. So, and to achieve that wire position, so how to do that? So first wire this true lumen as well as false lumen, and you can keep a IVUS in false lumen and then take this true lumen wire back into false lumen. So which all of this can be done under IVUS guidance. So once your wire is in the mid RCA, so then you just create a space here and then send a guide extension into this place, that is a mid RCA. And once that is done, go retrograde, cross the CTO, and bring this wire into guide extension and externalize it. So that gives you the clear wire position, which we wanted to execute our plan in the first place. So this is the wiring strategy. And you can see here, this is my first wire, so which is going into this side branch. That means it is in true lumen. And the second wire, which is just going into mid RCA, that means it is in the false lumen. And in fact, you can we did an IVUS and confirmed both wire positions as well. And then the true lumen wire, so exchanged to Gaia next 2, after placing, I think this is probably turnpike LP or Corsair. So after placing turnpike LP or Corsair into this, wire was exchanged to Gaia next 2, and then perforated back into false lumen down. So you can see that is what I'm doing. This is a Gaia 2 which came back into the false lumen, and then that was confirmed by IVUS. So this is IVUS. You can see there are 2 wires in the mid RCA lumen, and now you can see this one wire moving into the true lumen. So this is a wire and this is a true lumen. So the wire moved into true lumen. So that's a true lumen wire. So you can see here again, so these are 2 wires in false lumen here, and then you can see the wire coming into true lumen, moving into true lumen. Now it is in the true lumen. So that we confirmed up to ostium. You can see at the ostial RCA, this is a true lumen wire, this is a false lumen wire with IVUS in the false lumen to confirm the entire length of true lumen wire getting back to false lumen in the mid RCA. You can see this. This is a true lumen wire, true lumen wire, true lumen wire, and this is false lumen IVUS in wire, came back, and this is a proximal IMH at the aorto-ostial position. Fine. So once, this is IVUS of RCA, which I already explained. Now antegrade preparation is done. We dilated this and then took a trap liner, 6-French trap liner into mid RCA, and once a trap liner is in, so now our antegrade preparation is done. So now the next step is come retrograde and bring that wire into guide liner, so to achieve proper guide wire position to execute next plan. So you can see I came retrograde, and you can clearly see the loop within the mid RCA. It's badly loopy, and it is more loopy than what it was in the first intervention because of pseudoaneurysm. When a pseudoaneurysm forms, vessel becomes more tortuous. So that's what happened. So I escalated Y to Gaia next, but the problem is for Gaia next to take such a loops and come back into guide extension is really difficult. So Gaia next is essentially to cross the CTO segment here, which is very small segment remaining, and then exchange wire to more flexible polymer jacketed wire like Pilot 50 to get back into guide extension. That's what I did. So after perforation, I de-escalated wire to Pilot 50, and the Pilot 50 was advanced into guide extension with the double 2 curves at the tip. So that's what I'm doing. And once the wire is into the guide extension, we externalized it. Externalization with RG wire was done, and after that, as planned, we did a DES implantation in the CTO segment. This was the CTO segment, first DES implantation, which is like 2.7528, and then another second DES implantation for proximal true lumen expansion and false lumen sealing. So this is a 3.528 DES was done, and this was after deploying proximal and distal DES. You can see the pseudoaneurysm is there, but proximal false lumen is completely sealed. And now the plan is to put a covered stent here. So we took a covered stent, that's a graft master. I think it is 3.528 graft master, so which we deployed from this proximal stent to the distal stent with around 3 to 4 millimeter overlap with the distal stent. And this is the final result. You can compare. This was pseudoaneurysm, and so you can see now entire pseudoaneurysm is sealed, and RCA is completely patent and great, and it's filling nicely. Okay. Yeah. So this was a final IVUS. You can see the slit is 6 mm square, and proximally it's almost like 10.7 mm square. You can see this is the area of graft master, where the rays won't go out of graft master. So that's the area of graft master. Fine. So to conclude, proximal RCA CTO with calcified tortuous anatomy is one of the most complex site for connecting spaces, and often in my experience, most of my failed reverse cards are in the proximal to mid RCA, and tortuous RCA. And investment in preplasty after knuckle wire in a tortuous segment can be consequential. This is the first case of pseudoaneurysm which I have seen after investment procedure. So, and that can be attributed mainly to knuckling, both antegrade, retrograde, as well as it's a tortuosity of the vessel, and then preplasty, which I did with 3.5 mm balloon. Multiple factors cause this, and CT is a very, very important investigation in this to fill a lot of gaps in the understanding of anatomy, which angiography cannot give often. And planning is the key in such procedures. Planning wiring strategy and planning stanting. So all this is a key, and CT helps you very well, and this is a clear case how you can use CT in finishing your complex scenario or complex procedure. So thank you, and keep subscribe to my channel, and you can see more and more such case videos which changes your practice. Thank you once again.